Hello, hello, everyone. Welcome to Virtual Morning Report. For those of you that don't know me, my name is Anand Patel. I am a hematology oncology attending at the University of Chicago with a focus on patients with bone marrow disorders and leukemias. Also a member of the CP Solvers team, which is such a wonderful group of colleagues that I've gotten a chance to know over the last several months. And I'm so happy to see so many familiar faces in the audience for a hemonc specific virtual morning report. So we have Andrea and Chiara who will be helping us with scribing and teaching points. So why don't the two of you introduce yourselves and then we will go from there.
Hi, I am Andrea. I am a medical student in Lima, Peru, currently doing an internship at Roswell Park in New York.
Hey friends, so happy to see you since it's been a while. I'm also from Peru. I'm currently studying for the USMLE and I'm happy to be here today.
And with this being a subspecialty morning report, you know, we sometimes we have a little more liberty to kind of stray from the tried and true pattern of virtual morning report. That being said, I'm happy to serve as the sole discussant for this case, but I would love to have a co-discussant if I could. So if anyone's feeling up to joining me in the lukewarm seat, and essentially the two of us would tackle every aliquot together, I would love to have that opportunity. It looks like we do have a volunteer. It looks like Dhruv has thrown his hat in the ring. Dhruv, why don't you go and introduce yourself? And I believe we have a case presenter as well, Salman, who is a colleague of Andrea's. So Dhruv, why don't you introduce yourself? And then if Salman is on the call, he can go ahead and introduce himself as well.
Yeah, so hey everyone, I'm Dhruv. I'm a PGY1 in Med Peds at WMed up in Kalamazoo, Michigan. But currently at my parents' place, close-ish to Boston, actually. Going to be meeting with one of the regulars at CP Solvers, Kanu, tomorrow, since he is close by. But originally, I had a case that I'd wanted to present, but since you guys already have one, I figured I'll step into the lukewarm seat and discuss. It's been a while since I've been on because of inpatient and now being stuck in the emergency department. So.
Awesome. Thanks so much for joining me, Dhruv. And then is Salman on the call? And if yes,
Yes.
we'd love to have you go ahead and introduce yourself.
Hey guys, how are you? This is Salman. I'm one of the fellows at Roswell Park Cancer Center, PGY4, and I'm interested in malignant hematology, especially the myeloid malignancies. So it'd be fun. Dhruv, if you want to go ahead with your case, that should be fine with me as well, and I can discuss in that case.
Yeah, I'll leave it up to the two of you. I would, if we want to flip flop and have Salman join me in the discussants co-chair and have Dhruv present a case, or either way. In the meantime, though, while we're sorting that out, if we could go ahead and get the whiteboard pulled up, and we'll go ahead and dive right into it as soon as we can.
I think the case will probably be right up your alley, Salman. So if it's all right with you, may I present?
Absolutely, yeah.
All right, perfect.
Wonderful. So so we'll have Dhruv be our case presenter, and Salman and I will discuss the case together. Salman, you're talking to a fellow enthusiast when it comes to the myeloid malignancies and hematologic malignancies in particular.
Yes,
so, so we'll tackle this as best as we can together. So with that, sorry, go ahead, Andrea.
Salman is the founder of the EMON Fellows Network, and he recruited me to it. So he was the one who started that Twitter page.
So with that, thank you so much for that plug, Andrea. And Salman, would you like to use this opportunity to tell the folks in the chat a little bit about the Hem/Onc Fellows Network? And if anyone is interested, that way they can keep an eye out for some of the amazing programming and events that you've put on so far. I think you may be muted, my friend.
Yeah, I'm just typing in the chat. Yeah, also
I can type and you can talk. I can type and you can talk.
yeah, all right. So Hem/Onc Fellows Network, Andrea's typing. So it's just like a network of fellows. I just saw that renal or liver fellows had their own pages, ID fellows had their page. So I said, okay, we should have one too. It's just for us to come together, just discuss things and just talk about life and fellowship in general. We are not as educational as Dr. Patel and Andrea and you guys are, but we just talk about how can we build our career during the 3 years of fellowship. So
Salman, you're selling yourself short. So this network is incredible when it comes to things like practical career advice. They've had all sorts of speakers, including, how to do research as a fellow, the transition from fellow to attending, which was a topic I had a chance to speak about a little bit, and kind of everything in between. So it's been a wonderful opportunity. I think we've got our whiteboard ready to go. So why don't we let Dhruv start telling us a little bit about the chief complaint and the past medical history, or the HPI, and then we'll go from there.
Right. So this is going to be, I guess, sort of a familiar chief concern that that you guys as hematologists get, but it's epistaxis. I'll go into a little bit more detail for you guys. So this is a 65-year-old gentleman who presented to the hospital with 1 hour of persistent epistaxis that the patient describes as pouring blood. He also, he had to go to the ED in order to get this epistaxis to stop, because it wouldn't stop on its own, wouldn't stop when he tried just closing his nose for 10 minutes. Ultimately, it was able to be resolved with external pressure and a nose clamp. But while he was in the ED, he also mentioned having urinary retention, difficulty, basically feeling like he had to go, but not completely emptying his bladder, having dysuria, and also having an episode of black stool after his nosebleed, and then not having a bowel movement subsequently. Just to give a little bit more info, the patient was COVID positive about, I would say, 2 weeks prior to admission and received monoclonal antibodies around that time. He had also lost about 23 pounds since that time and had felt increasingly weak. Just to round out symptoms, has chronic shortness of breath with exertion, occasionally has a productive cough, no fevers or chills, no drenching night sweats, no easy bruising, no headache, no dizziness, no chest pain, and no palpitations. So I'm going to stop there for now. And I guess since epistaxis is a common chief concern that results in consults for you guys, I wanted to see what you guys would have thought about this.
okay, Dr. Patel, can I go first?
Yeah, please. Yeah, go ahead. And then I can add any additional thoughts I may have after you get a chance to discuss this aliquot. That would be perfect.
Sure, thank you. So, Dhruv, I assume you're seeing this patient after this emergency episode is resolved, or are you seeing this patient in the ED? Like, which is the setting for us?
So we are seeing this patient after he has been transferred from the ED that he was originally seen in and the epistaxis resolved to the hospital where he was admitted and ultimately received his higher level of care.
Sounds good. Great. Alrighty. So at this point, like I just want to what my thought process would be at this moment is, number one, we mentioned that the patient had nosebleed and some possible blood in his GI tract, and he had a recent COVID infection. Did the patient had any previous episode of epistaxis or bleeding?
No, this is the first time.
This is the first time it ever happened. Alrighty. So when it comes to epistaxis, the way I think about it would be, number one, is it some local cause, that is a cause inside the nose, or is it some systemic cause? Obviously, as a hematologist, I tend to jump to systemic causes more frequently than the local causes, but it's important to think about local causes because they are the more common ones. So any local injury in the nose, any dryness, any recent procedure in the nose, any foreign body, especially in younger patients, pediatric patients, any tumor, things like that would definitely come into play in those situations. The next thing that I will think about is systemic causes. So possible systemic causes, number one would be some hematological problem. Hematological problem in younger patients is different. In an older patient like this would be slightly different. So in younger patients, I would think more towards like ITP or like ALL or AML, like if the presentation also points towards that. The patient didn't have anything else. You mentioned no fevers or things like that.
He did not have any what you would describe as B symptoms.
Yeah, bruising and palpitations, everything. So the next thing that this patient has in their history is this recent COVID infection. So at times, what my thought process will go to is like, at times all viral infection can give you cytopenia. So can it be just like a platelet defects due to a recent infection? So that would be one of the differential at this point in my mind. Systemic factors like acute severe hypertension, it can cause epistaxis only as well. So that would be in my mind. So at this point, my differential diagnosis would be either a local problem in the nose or something like a thrombocytopenia, a problem related to thrombocytopenia due to a recent COVID infection. These are my two top differentials, but then my lower, like the rest of the list would be either ITP and AML, ALL, and I'll go from there.
Yes, Salman, I love that start, and in my mind, I agree. I think at this point we should keep things very broad and very simple. So epistaxis alone, we think about local causes. So as they're bleeding from Kisselbach's plexus, which is the most common site of nosebleed, and is that going to be due to trauma? Could it be some sort of local infiltrative process, as you had mentioned, like a mass? Something like a granulomatosis process that's then involving the nose as well? Or is it a systemic process as pertaining to hematologic issues? And really, in my mind, I think, is it a platelet issue or is it a coagulopathy issue? So it's hard to get a sense of which of those kind of three big things it could be, a local issue, systemic platelet issue, systemic coagulopathic issue. But I think the thing that concerns me the most about this case is that this patient has black stools as well. So isolated epistaxis, typically it's self-resolving, it's pretty easy to manage, and it doesn't recur. The fact that this patient is having bleeding from multiple sources makes me think that this is less likely to be a local issue much more likely to be a much more likely to be a systemic issue. The other thing is when thinking about urinary retention in the context of someone bleeding, I would be very interested in as we kind of get more history about this patient, and if he ends up being catheterized, seeing if this patient is passing blood clots, because blood clots in the urine can certainly be a cause for urinary retention. In terms of the history of COVID, Salman, you're right on the nose, where we have to think about, could this patient's previous history of COVID have predisposed him to either developing something like a thrombocytopenia, or could it have predisposed him to developing some sort of COVID-related coagulopathy, whether that's DIC or something else. We do know that the monoclonal antibody therapies are quite effective, so hopefully that has limited the sequelae of this patient's COVID. That being said, we certainly know that even with being treated with monoclonal antibodies, this patient may still have some of the complications associated with COVID. So those are my thoughts right now. And I would love to hear more about the past history and the exam, and we can kind of build on that differential from here.
So there is a point in the chat as well, and I kind of agree to this. Like a single episode of black stool can happen after a very big epistaxis episode, because the patient keeps on swallowing some blood and that can come out. But it usually happens after a few hours of, and you need to have a very significant epistaxis. Like maybe this patient, if had a 1 hour persistent epistaxis and only had 1 episode of black stool, that could be explained by just swallowing blood, but no more than that.
Yeah, I love clarifying that point about, yes, is the black stool truly melena related to a GI bleed, or is this related to the epistaxis by swallowing blood? And I agree, typically we can see black stools or melena related to epistaxis, but typically it's several hours after, because the blood has to have time to kind of be digested and then pass through the GI tract.
Yep, and you guys are on the nose. It was only 1 episode of it, and it did occur a couple of hours after he had that persistent nosebleed. So let me go into the southwest corner, and it seems like I am speaking too fast, so I will try to slow down as much as I can to make sure that everyone gets everything. Okay, so past history. In addition to that episode of COVID, he also has COPD, hypertension, and hyperlipidemia. In terms of medications, for that, the dysuria and urinary retention, they were initially suspecting an acute urinary tract infection. So he was given cephalexin or Keflex for his UTI. Otherwise, in terms of medications, he was on albuterol, amlodipine, budesonide and formoterol, lisinopril, rosuvastatin, and sildenafil. In terms of past procedures, he did have cataracts removed from both of his eyes. And then in terms of family history, just hypertension and hyperlipidemia and heart disease. In terms of social history, he is married. He is a retired railroad worker. And in terms of health-related behaviors, he previously smoked 2.5 packs per day of cigarettes for 35 years. But he quit about 21 years prior to presentation. He drinks about 1 to 2 cans of beer per week. But he hasn't had any alcohol for the last month. And he also smokes cannabis 1 to 2 times per week. And the only allergies he has are to sulfa drugs for which he gets hives. Do you want me to give the physical exam, or is this enough?
If you could go ahead and give the physical exam in this aliquot as well, Dhruv, that'd be perfect.
Sure. So, all right, vitals. Temperature of 101.4 Fahrenheit. Heart rate of 92. Blood pressure of 120/74. Respiratory rate 16. And saturating 92%, I believe, on room air. He eventually required around 2 to 3 liters worth of nasal cannula in order to keep his oxygen saturations up. Now, when we went to see him, he was resting comfortably in no acute distress. He did have conjunctival pallor, but otherwise his oral mucosa was moist. And he did also have some dried blood on the roof of his mouth. His neck was supple, and there was no lymphadenopathy. Cardiovascular-wise, normal rate, regular rhythm, normal S1 and S2, and no murmurs. Pulmonary-wise, normal. Actually, scratch that. On admission, he had decreased breath sounds at the bases, but otherwise he was clear. GI, he was not distended, soft, he was non-tender, no hepatosplenomegaly and no masses. The one point of shame is that we did not perform a rectal exam on him. The extremities were normal, with the exception of there being lower extremity pallor as well as some petechiae. And neuro and psych-wise, he was normal. He was alert, coherent, following all commands, 5 out of 5 everywhere, and reflexes were normal. And I will leave it there for now.
Great.
So like, I'm sorry if I missed it, but what about the local nose exam? Did you see anything inside the nose that was out of the ordinary, like a mass or a, a septal deviation or a bleeding point?
Just dried blood.
Just dried blood. Okay. And did you feel like when you did the examination of abdomen, did you feel the bladder by any chance?
No, there was no evidence of urinary retention.
Okay, good. All right. Yeah, so these two questions, I like when I do an examination, I always think about what and why I'm doing that. So, and that's how you all should train yourself as well. Like, okay, I'm looking into the nose just because I want to see if there is anything that is bleeding or not, and if I'm feeling the bladder because he didn't had urine output for some time. I want to see if he has a palpable bladder. It's okay not to do rectal examination if you have more information. I'm pretty sure you did, but if I was seeing this guy in ED, I'll make sure I do a rectal examination on him. Significant things on him are this, like he still is febrile after 2 weeks of his COVID infection, which is important. And he has pallor, which could point to having low hemoglobin, and he has petechiae, which again could point to a low platelet count. So these findings are the significant one, I think, on examination.
Oh, and I forgot to mention, he also had palmar crease pallor as well.
Okay.
Yeah, so those are the big things I take away too. I think I'm going to bring up one of Robbie and Reza's favorite things to talk about, which is the base rate of disease. And one thing to remember with COVID right now, unfortunately, is that the base rate of disease is still reasonably high. So you get lots of patients who have a prior history of COVID and then are having an acute presentation of disease that has nothing to do with their COVID. So it's still hard for us to tease out whether COVID is directly tied to this current presentation or whether it's just so happens to be that this patient had COVID 2 weeks ago. One question of clarification I had was the cannabis that he uses. Does he use any synthetic cannabis or spice, anything like that?
No, he probably wouldn't even know what that is.
So the reason I ask is about 1.5 years ago, there was a breakout of significant bleeding episodes in patients that were using synthetic marijuana. Ultimately, it was tied to potentially having some sort of warfarin type compound in it or otherwise. So these patients were having these incredible coagulopathies, INRs that were above 10, et cetera, after using synthetic marijuana. So something to kind of think about just when getting a good drug history. Looking at his medications, there's nothing that I think would be contributing to a bleeding diathesis or coagulopathy. So I don't see any other significant offenders. One thing to remember is that antibiotics and cephalosporins can cause thrombocytopenia, but it's not very common. So Keflex, maybe could be implicated, but hard to do so. And then on exam, the thing that really stands out to me is conjunctival pallor and palmar crease pallor are with incredibly low hemoglobin. So for example, you're not going to see pallor on exam when someone has a mild anemia, say a hemoglobin of even 8 or 9. Typically, you're thinking about hemoglobins that are definitely below 7, which is when you think about needing to transfuse patients to support them. And similarly with petechiae on exam, you don't typically see petechiae with just mild thrombocytopenia. Typically, the platelet count is under 50,000 or so. It is encouraging that we don't see, or that we didn't hear about any wet purpura, or what we colloquially call blood blisters in the mouth, because typically those are associated with a platelet count of less than 10. So hopefully that means this patient's platelet count isn't quite that low. And then the last thing I'll add is this patient is febrile. In someone who we have high concern for cytopenias based on their exam so far, so, I'm very worried that this patient will be anemic and thrombocytopenic. I think we should also be thinking about, will this patient be leukopenic and or neutropenic? And if yes, then we need to work this patient up for an source of infection and start antibiotics immediately to treat for neutropenic fever. The other thing I'll add is in patients that have neutropenia, you shouldn't be doing rectal exams because you can potentially translocate bacteria and cause bacteremia. So if this patient ultimately ends up being neutropenic, there was a very good reason for why a rectal exam was not done.
Sorry, I guess I was still muted. And yes, wait, huh? No, patient is patient 65 years old. He had smoked for 35 years. All right. So labs. I am not going to give the CBC first, as that will probably give away a couple of things. So I'm just going to do the electrolytes first. So sodium of 140, potassium of 4.4, chloride of 102, CO2 of 25, BUN of 20, creatinine of 1.27, glucose of 112, calcium of 8.3, AST of 104, ALT of 25, alkaline phosphatase of 87, albumin of 3.4, total protein of 6.2, and total bilirubin of 0.3. There was no direct. His PT was 15.8 seconds with an INR of 1.4. His PTT was 29 seconds. His fibrinogen was 237. His magnesium was 2.3. His phosphorus was 3.8. Okay, now I'll give the CBC. White blood cell count of 95.5. And an absolute neutrophil count of 1,000. Hemoglobin of 7.4. So hematocrit of 22.8. Platelet count, 5. Also, MCV is normal at 96.6. I don't believe we got a retic count.
Do we have a full white count differential, Dhruv?
We do. So I'll get lymph. So basically the differential is 90% blasts. 8% lymphocytes, 1% neutrophils, 1% monocytes. Oh, and also, no, this guy did not travel. To answer Christian's question in the chat.
Okay. Anything else in this aliquot, Dhruv, or should we get ready to discuss?
I would say discuss now. The next aliquot will I'd want to see what test you'd want to get before I reveal the final diagnosis.
Sure. Well, we'll let Salman as our fellow. This is probably a call that Salman has fielded in the middle of the night many a time in the past year.
Yeah.
So let's
probably.
let Salman talk a little bit about it.
Yeah. So the biggest thing at this point would be to look at the peripheral blood smear. Like if the pathologist already looked at it, then it's okay. Otherwise, you're gonna be called in to do that. So peripheral blood smear is the most important test at this moment. No matter what the auto machine reads about the blasts, you have to see them and confirm them. Rest of the presentation is very typical of acute leukemic process. I won't go any further than that till I get the whole information. So my first step to go for would be a peripheral blood smear and a flow cytometry on the peripheral blood. And I'll go from there. At this point, also, I wanna, a few things that I need at this point would be a LDH level and a uric acid level. The reason is I wanna make sure the patient, if this is a acute leukemic process, the patient is not having the life-threatening complication of tumor lysis syndrome at this point.
Perfect. And to add to that, so let's go through this systematically. So we have a white count of 95,000, 90% blasts. We do not know yet if these are myeloid blasts consistent with AML or lymphoid blasts consistent with ALL. So how are we going to tease this out? Exactly how Salman said. We're going to look under the microscope and we are going to look at these blasts and first make sure that they are blasts. Second, try to get a sense of, are these lymphoid or myeloid blasts? So myeloid blasts in general have more granularity within the cytoplasm. And the other thing we want to do is make sure that if it does look like myeloid blasts, that they don't look like promyelocytes, which would then concern us about a diagnosis of acute promyelocytic leukemia, which is a subtype of AML, but we treat very differently. So what are the smear findings that we look for in someone with APL? We look for bilobed nuclei, so nuclei that kind of have a cleft in them like this. We look for hypergranularity in the cell, in the cytoplasm, and we look for hour rods, which are very thin eosinophilic granulations that basically look like little sticks stacked upon each other. So hour rods are seen in myeloid malignancies, and APL typically has more hour rods than other myeloid malignancies. Why does this matter? The reason it matters is because APL, over 90% of patients are cured with appropriate therapy, but the mortality risk is all early on because of bleeding and coagulopathy complications. So this is one of the few times in oncology where if you're worried about someone having APL, you start treating them as if they have APL before you even confirm the diagnosis, which is with all trans-retinoic acid, or ATRA. So in my mind, the important tests to send off for this patient right now is a peripheral blood smear. Look for findings concerning for APL, and if there are findings concerning for APL, administer ATRA. Send flow cytometry to look for cell markers that are consistent with myeloid versus lymphoid blasts. And at our center, we're very lucky to have rapid testing that can be sent for both the fusion protein seen in APL, which is PML RARA, retinoic acid receptor alpha. And that test can be back within 24 hours. It is a PCR-based test. We also have a similar test for BCR-ABL, which is a fusion protein that can be seen in CML, chronic myeloid leukemia, or ALL, acute lymphoblastic leukemia. So I would be sending both of those tests from the peripheral blood as well. So I'd be sending a smear, flow cytometry, and then PCR-based testing for to help rule in or rule out the presence of the PML-RARA fusion protein, which we see with APL, or the Philadelphia chromosome fusion protein, BCR-ABL. In terms of the epidemiology, so this is a 65-year-old patient. Acute myeloid leukemia is the most common acute leukemia in patients this age. ALL is predominantly a disease of pediatric, adolescent, and young adult patients, although we do see ALL in older patients as well. It's just not nearly as common. So the big branch point here is this concerning for APL or not? And then we go from there. Other things that need to be done in management. This person needs platelets. We typically transfuse when platelet count is less than 10,000. I would also treat this patient as if they had a neutropenic fever, because although technically their ANC is 1,000 and a neutropenic fever requires a neutrophil count of less than 500, in patients with uncontrolled leukemia, we have to ask ourselves, are these neutrophils functional? Are they doing what they're supposed to be doing? So you could invoke what we call functional neutropenia for this patient. He's sick, he's febrile. I think starting antibiotics and doing an infectious workup with in a patient with a likely new diagnosis of acute leukemia should absolutely be done. And I will stop right there.
All right, so to answer some of your questions, uric acid was 8.1. So yes, he was started on allopurinol and was given massive amounts of fluids. As for the peripheral smear, it basically just confirmed what the automated cell counter had done. Let me see if I can find the damn thing. Okay, smear is leukocytosis with circulating blasts, medium to large in size with scant cytoplasm, fine nuclear chromatin, and prominent nucleoli. No hour rods identified. Correlation with flow and a bone marrow biopsy is recommended. Normocytic anemia with increased anisocytosis, but no definitive morphologic evidence of hemolysis. And thrombocytopenia with morphologically unremarkable platelets. And PML-RARA was negative.
Is that the end of this aliquot, Drew?
Yes, the next aliquot will be the bone marrow biopsy, which will reveal the final diagnosis.
Great. Salman, what are you thinking for this patient?
Yeah, at this point, as you said, my biggest differential at this point would be AML, just given all the presentation, his age, and did we send the I'm sorry if I missed, did we send the rapid BCR-ABL and did it result?
I don't believe that was done.
Okay, that's fine. But I think we still like we in these sort of situation we can do BCR-ABL from peripheral blood as well, because that gives us an answer for as you age. Like this is just one of the points. As you the ALL which is present in older patient is more likely to be Philadelphia positive than Philadelphia negative. So like it increases, the frequency increases with age. Yeah, and then obviously the next best step is the bone marrow biopsy to finally confirm the diagnosis. In the meantime, if, for example, you are at night and this patient is with you, just make sure that you do all the steps, like give them fluid, give them allopurinol, just keep checking the tumor lysis labs, which are your potassium, your creatinine. His creatinine is also slightly, like, I'm not saying it's elevated, with 1.27, and I don't know what his baseline is, so I'll definitely keep an eye on this thing. And keep monitoring phosphorus, and give him antibiotics, as Dr. Patel mentioned, and do a blood culture set at some point. I would also ask for a chest X-ray, just because he was requiring oxygen at some point, and he is febrile neutropenic, so just making sure that he doesn't have a pneumonia.
Dhruv, was this patient on oxygen at baseline due to a COPD? I may have missed this.
No, he was not.
Okay. The one additional thing I will add to everything that Salman has mentioned is we do have to consider whether or not this patient is having signs or symptoms of what's called leukostasis. So symptoms related to having a high peripheral blast count. So typically if someone has a blast count that is over 50,000 in total, so for this patient, 90% of 95, so he probably has about 85,000 as his absolute blast count. So patients with an absolute blast count of over 50,000 are at risk of leukostasis. Leukostasis is more common in myeloid leukemias as opposed to lymphoid leukemias, because myeloid cells are bigger and stickier. So signs and symptoms of leukostasis: shortness of breath, neurologic symptoms, confusion. These would be the things that we're worried about. In this patient, he has some signs of respiratory distress, but is well controlled on 2 liters nasal cannula. So if he does have leukostasis, it's likely very mild leukostasis. The way that we manage leukostasis is, in mild cases, use drugs that can help to cytoreduce, meaning bring down the white blood cell count. So something like hydroxyurea if we're worried about AML, or steroids if we're worried about ALL. In cases of severe leukostasis, so patients that may need something like BiPAP or have had a stroke, we actually think about a process called leukapheresis, where the white cells are pheresed off. So this is not a patient that I'm worried about doing leukapheresis in, but I would think about, do we need to start some sort of cytoreductive agent like hydroxyurea or steroids while we're sorting out what the final diagnosis is. Ultimately, as good as our pathologists are at trying to look at cells under the microscope, flow cytometry is what will ultimately give us a final diagnosis of AML and AL or versus ALL. And the bone marrow biopsy will be critical to help clinch the diagnosis as well. So I'm eagerly awaiting the flow cytometry and the bone marrow biopsy for this patient.
All right. So the bone marrow biopsy. Oh, okay. So to answer all of your questions, yes, he was started on hydroxyurea. The admonishment that we get in our hospitals, at least on the pediatric side, is if you have a patient where you have a concern for a leukemia, do not start steroids until you get a peripheral smear evaluated by a pathologist, because otherwise you're already treating the disease technically, since you're cytoreducing, and it may affect the quality of any further studies that you might get, but that's always a balance. As for the bone marrow biopsy, he had hypercellular bone marrow at 90 to 95%. And sheets of blasts occupying approximately 90% of marrow cellularity, with the blasts looking like they do in the peripheral smear. As for flow, the blasts expressed diminished signal CD45 diminished signal CD33, partial CD117, partial CD64, and diminished CD38. And in terms of other molecular genetic studies, at the time that this patient was seen by us, the only one that we had was for FLT3 ITD, which was positive with an allelic ratio of 0.9. All of the other analysis like karyotype, fish panels, other next generation sequencing, and I think TP53 mutation were in process. And that was the and thus the final diagnosis. This patient had AML that was FLT3 ITD positive. And so he was started on, actually he was healthy enough that we started him on 7 and 3 with midostaurin as his chemotherapy regimen.
Wonderful. Thanks for sharing that case with us, Dhruv. Salman, do you want to talk just for a couple minutes? I know we don't have a lot of time left at 7:53, but Salman, do you want to talk a little bit about what considerations go into the right, how we pick a therapy for someone with a new diagnosis of AML? Because in this day and age, there are actually quite a few different therapies that we consider and think about. So what are the kind of things that are on your mind when thinking about what's the right therapy for a patient?
Yeah, absolutely. So, so for AML, the treatment, 7+3 that you mentioned is actually a very high dose of continuous cytarabine for 7 days and 3 days of high dose daunorubicin. So for this high dose, giving for someone this high dose of daunorubicin, their heart needs to be really strong. So I'm pretty sure at some point this patient would have had an echocardiogram that would have demonstrated a very good ejection fraction, because even if they are like borderline, you don't want to kill them with your chemotherapy essentially. So from 7+3 came into existence, and Dr. Patel, if I'm wrong, you can correct me. It came around 1960s to 70s era, and it became the standard of treatment for our myeloid malignancy patients, and it remained standard till this last decade in like 2010s. In 2010s, we finally started to get more medications, more targeted medications. So one of the targeted medication that targets the FLT3 is midostaurin, which we did. So it's based on the Viali trial, if I remember right, that showed that midostaurin combined with 7+3 was more useful, and it increased the chances of getting patients into disease under control, for which is called remission induction or complete remission. There are other mutations, like there is a mutation in IDH1 or IDH2, and there we have targeted agents for that. And finally, if the patient is not healthy enough, we have other agents which are something called a hypomethylating agent, azacitidine and decitabine, and there is a BCL inhibitor called venetoclax, which can be combined for less healthy patients. The thing at not a fellow level to understand about leukemia treatment, and I'm pretty sure this might have been discussed previously in some of your episodes, is first of all, you have to get them into something called remission by doing a high dose induction chemotherapy, and you get quite a few patients into remission, but then you have to consolidate the remission with more chemotherapy or possibly an allogenic stem cell transplant. And after that, some patients even go on to maintenance therapy as well. So this part, 7+3 plus midostaurin, would be an induction treatment for this patient. And then after that, depending on how he does, he go to get for further therapy. And
that will consolidate his induction, and then after that, you just monitor for recurrence. The problem with AML or myeloid malignancies is they tend to come back despite all our efforts.
Yeah, beautifully put, Salman. So the thing that I'll add to take away for, like, so a lot of the discussion that we had, particularly about what therapy to pick, is very pertinent as a fellow or as an attending. But I think the big things to remember, if you're a resident, a medical student, some other sort of student or clinician taking care of a patient, is if a patient is what we call fit, meaning we think that they would be able to tolerate high dose chemotherapy, we typically use this regimen of 7+3. If a patient has comorbidities where we think intensive chemotherapy will be too hard on them, or the risk of it outweighs the benefit, then we most commonly use a regimen of hypomethylating agent, two of which are azacitidine and decitabine, combined with the oral BCL2 inhibitor venetoclax. I've chatted in a link that is written by my colleagues at the University of Chicago, including my mentor, Teosi Odenike, who leads our leukemia program. And it kind of very nicely lays out what our treatment approach is at the University of Chicago for patients with a new diagnosis of AML. But as Salman said, most cases of AML can only be cured with transplant. So the goal is to get patients into a remission and then take them to transplant if they have a good functional status. So there are many patients who transplant cannot be considered in due to comorbidities or otherwise. So with that, thank you so much for that incredible case through. Let's turn it over to Andrea to run us through our teaching points, and then we can let everyone go from there. But a wonderful case, lots of opportunity to talk about some of the basics when it comes to workup of leukemia and complications to watch out for. So thank you so much for sharing this case. And Salman, I wouldn't guess that you're a first-year fellow. You sound like you're a senior fellow. You're ready to be done with training. So excellent job walking through this case.
Yeah, I just got done with the 2 months straight of inpatient. So I just did have these things for 2 months. So that's why.
Yeah, Salman did a lot of research in BMT too, so he's expert on this. So we started with a case of epistaxis. So we think about local cause, something that can be in the Kisselbach plexus, like it could be dryness, a tumor, an external object, especially in kids, or versus something systemic, like could be an hematological malignancy, or something benign, acute hypertension, or maybe because the patient is post-COVID, he may be having any late effect of COVID. Because the patient appears to be bleeding from multiple sources, it can be systemic, but it can also be that it's because the several hours after the epistaxis, because the patient swallowed the blood, is because he has this melena. So it's something to think about. And while taking the drug history, we should always ask which type of marijuana, because there have been a breakout of bleeding episodes of synthetic marijuana, possible due to warfarin contaminant. Another thing to have in account is cephalosporins that are very common antibiotic can cause thrombocytopenia. And when you see on the physical exam, a pallor is visible with hemoglobin below 7, and petechia below 150,000 platelets. In order, and when you have patients that could be neutropenic, you should defer the rectal examination because you can translocate the bacteremia and make it worse. So in this case, we thought it could be APL. 90% of the patients are cured, but they have a very high mortality due to complications. And there is this PCR test called PML-RADA. And you start to treat the patient with retinoic acid before being fully confirmed because of the complications. Something that comes in the States very often. MLN is more common in patients of this age, and ALL is more common in children, ALL. And because this patient maybe in a leukemic process, they may have functional neutropenia and should be treated as neutropenic fever, as patients with neutropenic fever. And then in this patient that has leukostasis, that has a high peripheral blast count, is more common in yellow leukemia, and it can present with shortness of breath and neurologic symptoms. And normally the treatment is hydroxyurea, steroids, or leukophoresis. And now with the technology that we have today, the flow cytometry gives us the expression of what the patient has and can get a better diagnosis than just looking at the pathology. So the flow cytometry rolls over. And then we have this patient with MLL. So we need to think about if the patient is fit or the patient has comorbidities, and based on that, you decide the treatment. And the goal is to put them in remission, and if they are fit for it, they can later have a transplant. Thank you very much to everybody.
Thanks so much, Andrea, for those wonderful teaching points and summarizing an hour into 2 minutes, basically. So enjoy the rest of your day, everyone. Thanks so much for joining us, and hope to see everyone soon. Take care.
Thank you, guys. Thank you
Hi,
so
guys.
much for